Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. If you are still not registered, do remember to subscribe so that you can get regular notifications of any future uploads. In this next video, I'm going to be discussing with you a new brachial plexus block technique which goes by the acronym SeTB. It's also referred to as Selective Trunk Block, and its role as an all-purpose regional anesthetic technique for upper extremity surgery. I take this opportunity to thank the organizers for inviting me to speak at this meeting. Before I begin, I'd like to declare that I have no conflict of interest whatsoever relating to this presentation. During this presentation, my objective is to share with you a preliminary experience on a new regional anesthetic technique that we describe as selective trunk block. It goes by the acronym SeTB. We've been working at trying to evaluate it as an all-purpose regional anesthetic technique for upper extremity surgery. The analogy would be whether we could use it like the spinal of the upper extremity, irrespective of the site of surgery in the upper extremity. Before we go into the details of selective trunk block, I think at this juncture it's important to address the issue as to why we need a regional anesthetic technique that can be used as an all-purpose technique or spinal anesthesia of the upper extremity, given that we have different techniques available to us in our armamentarium, like the interscalene, the supraclavicular, infraclavicular, and the axillary brachial plexus block. During an interscalene brachial plexus block, a transverse oblique scan is performed in the neck to identify the ventral ramus of the C5 and C6 located between the scalenus anterior and the scalenus medius muscle. The needle is inserted in plane from a lateral to medial direction, aiming for a periplexus location of the needle adjacent to the C5 and C6 ventral ramus, whereby the local anesthetic is injected to produce anesthesia and analgesia for shoulder surgery. So therefore, we target the C5 and C6 ventral ramus during an interscalene brachial plexus block and is preferred for shoulder and upper arm surgery. A limitation of this interscalene block is that inferior trunk sparing occurs in as high as 82% of individual. Therefore, it is not suitable for surgery at or below the elbow. Low interscalene brachial plexus block has been described to try and circumvent this limitation. However, even with large volumes of local anesthetic, although there is more distal spread of the sensory motor blockade, anesthesia or surgical anesthesia of the hand and forearm only develops in about 15% of individuals. Therefore, it would not be suitable for the entire upper extremity. Supraclavicular brachial plexus block is often described as the spinal anesthesia of the upper extremity because it produces very rapid onset of sensory motor blockade of not only the arm but also the forearm and the hand, and is traditionally not used for shoulder surgery because of the concerns of suprascapular nerve sparing. Inferior trunk sparing also occurs in as high as 30 to 35% of individuals, even with the corner pocket injection that has been described. Nevertheless, it has been successfully used for ambulatory arthroscopic surgery, albeit with the use of very large volumes of local anesthetic, sometimes up to 65 mils of local anesthetic, volumes that are rarely used in modern day regional anesthetic practice. Infraclavicular brachial plexus block targets the chords of the brachial plexus at the lateral sagittal infraclavicular fossa. It's used for surgery at or below the elbow. Axillary brachial plexus block targets the four major terminal nerves of the brachial plexus, i.e. the median, radial, ulnar, and the musculocutaneous nerve. It produces very rapid onset of sensory motor blockade of these four terminal branches An axillary brachial plexus block is predominantly used for surgery distal to the elbow. The recent COVID-19 pandemic has surely brought a lot of doom and gloom across the globe. But with it, it has also brought a lot of opportunities. And one of these opportunities I'd like to share with you. When you look at patients who present for humeral fracture surgery, they can be challenging in that none of the currently available regional anesthetic techniques of the upper extremity can provide complete surgical anesthesia for these patients. Particularly during this pandemic, when most practices have been trying to avoid the general anesthesia in a quest to try and minimize aerosol generating procedures like intubation and spread of infection within the OR. Regional anesthesia has become the go-to for most of these procedures. But when you try and find a regional anesthetic technique for these humeral fracture surgery, particularly the upper humerus, then you're left with very little choice. Hybrid techniques have been described, i.e. a combination of axillary and interscalene brachial plexus block, described by Dr. Urme many years ago, interscalene axillary brachial plexus block, or an interscalene supraclavicular brachial plexus block, or as I alluded to previously, infraclavicular with a suprascapular nerve block. However, a limitation of these hybrid blocks are they require large volumes of local anesthetic, sometimes up to 50 mils of local anesthetic drugs. Sarah Madison and the group from San Diego, in their paper on ultrasound-guided root trunk interscalene block for hand and forearm surgery, described that it would be desirable to have an all-purpose brachial plexus technique for upper extremity surgery. It would change many years of our practice of using an individual technique and many different approaches to the brachial plexus. So with this, we suggested that selective trunk block would be a simple alternative to the hybrid brachial plexus block techniques for proximal humeral surgery. We've also demonstrated that the SeTB can be used to produce surgical anesthesia of the entire upper extremity in this case report. It is based on the principle that majority of the innervation to the upper extremity go through the superior, middle, and inferior trunk. So if you can selectively block the superior, middle, and inferior trunk, then you can, in principle, block the entire sensory motor blockade supply to the upper extremity. So therefore, it is vital that we are able to accurately identify the three trunks of the brachial plexus. And this is based on an ultrasound imaging technique that goes by the acronym SUIT. It's a sequential ultrasound imaging technique that we have recently described to identify the individual elements of the brachial plexus. The sequential ultrasound imaging technique is a transverse ultrasound scan sequence that starts from the supraclavicular fossa and identifying a few well-known sonomorphological features, you can determine accurately the various elements of the brachial plexus. In brief, it is a sequential scan over 7 contiguous sites starting from the supraclavicular fossa. You identify the C7 transverse process, and then further cranial to that you identify the C6 transverse process with the C6 ventral ramus. Thereafter you identify the C5 transverse process with the C5 ventral ramus. The transducer is now manipulated in a caudal direction to see the fusion of the C5 and C6 to form the upper trunk, followed by the neural stack of the upper trunk, middle trunk, and the C8, and thereafter the formation of the inferior trunk at the corner pocket. So this starts by a scan at the supraclavicular fossa. You can see here the trunks and divisions of the brachial plexus are located superior and lateral to the subclavian artery. While for many this may be referred to as a bunch of grapes, but if you look very closely at this and you do a sequential scan, you can then say that this is indeed the suprascapular nerve. This is the posterior division of the upper trunk. This is the anterior division of the superior trunk. This is indeed the posterior and anterior divisions of the middle trunk. And this is the inferior trunk lying in the corner pocket relative to the subclavian artery and the first rib. Second, you translate the transducer slightly cephalad to identify the C7 transverse process, which has a single posterior tubercle, and anterior to that lies the C7 ventral ramus, with the C6 lying contiguous and cranial to that position. Cranial to the C7 transverse process, the C6. The C6 also has a very pathognomonic or very typical sonomorphological feature. It has a very prominent anterior tubercle and a much smaller posterior tubercle, and the C6 ventral ramus lies in between the two as it's emerging from the intervertebral foramina. The C5 lies proximal to the C6. As you can see here, it's a much smaller ventral ramus in size compared to the C6 and the C7. From the C5, you translate the transducer in a coded direction where you see the fusion of the C5 and C6 to form the superior trunk. The middle trunk, which is the continuation of the C7, lies distal to it, and caudal to that lies the C8 ventral ramus. This can also be identified by its position on top of the T1 transverse process and the first rib complex. You can see this large hyperechogenic line with this acoustic shadow. So this is a bone. So this is your T1 transverse process and the first rib complex. So this neural stack formed by the superior trunk, the middle trunk, and the C8 ventral ramus is our primary ultrasound window or the target one of the target ultrasound windows for the SeTB block. If you follow the superior trunk more distally, you can, in some individuals, see the very accurate separation of the superior trunk into a suprascapular nerve, a posterior division, and an anterior division. This arrangement from a lateral to medial has been described as the spar of the brachial plexus. So it's also an important sonomorphological feature in the brachial plexus highway, where you can see the three divisions of the superior trunk. Caudal to that lies the middle trunk, and the C8 can be seen either on top of the first rib transverse process complex or sometimes even on top of the pleura, as you can see here in this individual. Once you have identified the C8 distal to that, you can now see how the T1 emerges from under the clavicle, under the first rib, beg your pardon, to join the C8 to form the inferior trunk. As you will see here, the C8 is located on top of the first rib. You can see the T1s coming from underneath to fuse with the C8 to form the inferior trunk at the corner pocket. As you see here, this is the C8. The T1 comes from underneath the first rib, and it goes around, swings around to join the C8 to form the inferior trunk at the corner pocket. Using the sequential ultrasound imaging technique, or SUIT, we've also demonstrated recently that it is possible to identify most of the superficial elements, particularly the C5, C6, C7 ventral ramus, including the superior trunk and the middle trunk with the suprascapular nerve, in about 90 to 100% of individuals. The T1 and the inferior trunk are more difficult to identify, but even these structures can be identified in about 40 to 60% of individuals respectively. We've also demonstrated that SUIT is a reliable technique in terms of when you look at inter-rater agreements. The inter-rater agreement of kappa was perfect for most of the superficial elements, as I alluded to, particularly the C5, 6, and the superior trunk, and it was moderate to fair for the other elements. This is not bad, given that this is a new technique that we are all becoming familiar with. With experience, I'm confident the results would be even. So now let's take a look at selective trunk block based on these basic fundamentals. SeTB is based on the principle that majority of the innervation to the upper extremity arise or pass through the three trunks of the brachial plexus. Therefore, targeted injections of the individual trunks of these brachial plexus using small volumes of local anesthetic we hypothesize would produce surgical anesthesia of the entire upper extremity that should be adequate for surgery not only of the shoulder and the proximal humerus, but also of the elbow and the forearm, or a combination of either of any of these surgical procedures. So therefore, it is in principle has the potential to become an all-purpose regional anesthetic technique for upper extremity surgery by blocking the ventral rama of C5 to T1. And it is with these objectives that we set out to investigate this technique of SeTB. As you can see here, patient is lying supine with the ipsilateral arm in a neutral position, the head turned to the contralateral side. The ergonomics are like so, as you can see in the top left image. Under strict aseptic precaution, a transverse oblique scan is performed in the supraclavicular fossa, and then we identify the target acoustic window, as I mentioned before. It's the neural stack of the superior trunk, middle trunk, and the T1, C8, beg your pardon. So the neural stack of superior trunk, middle trunk, and the C8 on top of the transverse process of T1 and the first rib complex is the first neural target. Under local infiltration, the needle is introduced and injections of the superior and the middle trunk are performed. Thereafter, the needle is withdrawn, and using a second injection in local infiltration of the supraclavicular fossa, a further 10 mils of local anesthetic is deposited next to the inferior trunk at the corner, close to the corner pocket. So currently we are injecting 7 mils at the superior trunk, 8 mils at the middle trunk, and 10 mils at the inferior trunk, giving us a total of 25 mils of local anesthetic. This is from another perspective. You can see the patient is lying supine with the head turned to the contralateral side under strict aseptic precautions. A high-frequency linear transducer is being used to produce a transverse oblique scan of the brachial plexus. Once the target ultrasound window is achieved, under local infiltration, the needle is introduced to perform a periplexus injection of the superior trunk. The needle is redirected after the superior injection to inject the middle trunk, which is just caudate to the superior trunk, 7 and 8 mils of local anesthetic, which is a combination of lidocaine and levobupivacaine currently with epinephrine. And then a second injection is performed at the supraclavicular fossa at the corner pocket of the subclavian artery and the first rib. In the sonogram, this is what you can see here: the C7 transverse process with this very typical sonomorphology. The posterior tubercle, you can see the C7, 6, and 5. The C5 and 6 fuse to form the superior trunk, you can see here. So it's the superior trunk, the middle trunk, which is continuation of the C7, and the C8. They are lying on top of this bony complex that I alluded to before. The first injection is performed in a periplexus location next to the superior trunk. It's withdrawn, redirected to the middle trunk, close to periplexus to the middle trunk. 7 and 8 mils of this local anesthetic mixture is injected at these two sites respectively. Thereafter, a third through a second skin puncture, the corner pocket is injected for the inferior trunk at the supraclavicular fossa. One must note that because the needle is maneuvered through the middle trunk, one must pay attention to the position of the dorsal scapular and the long thoracic nerve within the middle scalene muscle in this situation. Just a few video loops to demonstrate to you. You can see here, this is the scalenus anterior and the medius. So to your left is lateral. And you can see here, this is the T1 transverse process and first rib complex, on top of which lies the C8, and then the middle trunk and the C5 and 6 forming the superior trunk. Then advance the needle from a lateral to medial direction. You place the needle in the periplexus position after saline hydrodissection, 7 mils of a combination, 1-to-1 combination of 2% lidocaine with 1 in 200 epinephrine and 0.5% bupivacaine is added, is injected at this level. Thereafter, the needle is redirected to the same skin puncture and repositioned adjacent to the middle trunk, which is a continuation of the C7 within the interscalene groove, and 8 mils of the local anesthetic mixture is injected. Once this is done, the needle is withdrawn and a second skin puncture is made at the supraclavicular fossa, and like a supraclavicular brachial plexus block, you now advance the needle. The only difference you find here is that because of the initial injection, there is usually hydrodistension of the supraclavicular fossa, and it makes it easy to place the needle within the subfascial elements of the brachial plexus at the supraclavicular fossa, where 10 mils of local anesthetic mixture is then injected. We've now gained quite a relative experience with respect to this, particularly when you're looking at proximal humeral. As you can see, this is a pathological fracture of the humerus undergoing intramedullary nailing. Patient is lying again supine here. After the block, you can see patient is in the head-up position in a semi-beat chair. So it can also be advantageous because of the detrimental effects of general anesthesia on cerebral perfusion and reports of cerebral vascular accidents following surgery in some of these unfortunate patients. So if you can avoid it in this beat chair position by giving regional anesthesia with a more stable hemodynamics, it is desirable. You can see here patient is now listening to music through a headphone. They are sedated with dexmedetomidine. The respiratory function is monitored for any apnea or respiratory obstruction, and surgery continues under the effects of the SeTB, and thereafter you can see here the intramedullary nail has been placed. The proximal interlocking nails are placed at the upper head of the humerus, close to the head of the humerus, and then the distal interlocking nails will be placed closer to the elbow. A word of caution when you perform selective trunk block. The transverse cervical artery is very closely related to the superior trunk, as you see. It always, more or less in most of the individual, it goes on top of the scalenus anterior and then crosses over to the other side. But in some individual, it may also bisect the interscalene groove between the superior trunk and the middle trunk. So we believe it is imperative to identify this artery so that you don't inadvertently puncture this artery or inject interarterially, especially if it is within the interscalene groove, and then perform the superior trunk block or the SeTB slightly above or below the plane at which the artery is located. So what have we learned so far? As part of our initial investigation, looking at the selective trunk block, I've shared with you the sono anatomy and the technique so far. Let's now take a look at the block dynamics and its effect on phrenic nerve function. In this cohort of 30 patients of different ages, mostly adult patients, undergoing a variety of operations from the proximal humerus to the hand and wrist, or a combination of one or the other, that was performed mostly under regional anesthesia and sedation, but there was a whole group of individuals who wished not to be sedated, so 23% of them had it with the regional anesthesia only. As you can see here, this is a graph showing you the sensory score from 0 to 100, 100 being normal and 0 being anesthesia, in the distribution of the axillary, muscular, cutaneous, radial, ulnar, and the median nerve. As you can see here, over a 45-minute observation period, there's a very rapid decline in the sensory scores. Take the red as a summary of the whole data. The onset of sensory block of the axillary, muscular, cutaneous, and the radial nerve are much more quicker as compared to the median or the ulnar nerve. This may be related to, again, the earlier injection of the superior and the middle trunk. This is a motor score. To your left is the mean motor scores, and to the right is the median and interquartile motor scores on a range from 0 to 2 in the Likert scale. You can see here that the motor onset of blockade of the axillary suprascapular, given that suprascapular does not have a cutaneous innervation, it only supplies the shoulder joint but without a cutaneous innervation of the skin. It has musculocutaneous and the radial nerve. You can see here again the C5, 6, 7 components are much earlier affected than the C8 and T1. When we looked at the onset of sensory and motor blockade, defined as a sensory score less than or equal to 30 and a motor grade of less than or equal to 1 in the Likert scale of 0 to 2, you can see here that there is a rapid onset of sensory blockade in all the 5 nerves. The axillary, musculocutaneous, radial, ulnar, and the median, and the summary data also you can see here. There is almost onset of with as early as 10 minutes. And the motor grade is also rapid decline in motor function in all the major nerves evaluated. So much so that the onset of motor blockade of the axillary, suprascapular, and musculocutaneous nerves and the radial nerve are much faster when compared to the median nerve. The next question that we would like to address is, what is the effect on the phrenic nerve? As you can see here, this is M-mode ultrasound that we performed in our patients. We are able to perform them using in the supine position, and you can see here that the diaphragmatic exertion in the normal breathing, quiet breathing, and to your right is the diaphragmatic exertion on maximal deep breathing. And this is deep breathing, diaphragmatic exertion on deep breathing after the block. As you can see here, compared to the left, which is before the block, there is a rapid decline or decrease in there's a decrease in diaphragmatic exertion at 30 minutes. Also, when we looked at the sniff test, paradoxical movement could be detected in many individuals. As you can see here, there's a negative dip. That means the diaphragm is moving away from the transducer. So this indicates a complete paralysis of the diaphragm. So hemidiaphragmatic involvement, as defined by these criteria, that means the involvement less than 25 was no paresis. Anything more than 75% decrease in diaphragmatic excursion was complete. And between 25 and 75 was defined as partial, a criteria that's very frequently used to define hemidiaphragmatic involvement. We found that complete and partial hemidiaphragmatic involvement was detected in 80% of our patients with the dose that we used. Overall reduction in diaphragmatic excursion was about 62%, and paradoxical movement was detected in as high as about 30% of these individuals. A word of caution is that our patient studies had normal respiratory function, so given its very high diaphragmatic involvement, this would be a prohibitively high rate to be used in patients with respiratory disability. So in conclusion, selective trunk block is a novel regional anesthetic technique that we have successfully used for surgical anesthesia of surgical procedures involving not only the shoulder and the upper humerus, but also the elbow, forearm, and the hand. So we use it kind of a spinal anesthesia of the upper extremity, being particularly useful when we have used it in combination of our surgical procedures of involving not only the shoulder and the upper humerus, but also in combination with hand or forearm surgery. The phrenic nerve involvement of 80% is prohibitively high for it to be used in every patient as an all-purpose regional anesthetic technique. I think it would be too good to be true to be able to use it in every individual, like spinal anesthesia of the upper extremity. So patients who have respiratory disability would be a contraindication to the use of SeTB in the currently used doses that we are using. There may also be an impact of SeTB on teaching and learning of USGRA for the next generation of regional anesthesiologists, because using this simple single technique, you could perform majority, maybe more than 90% of individuals, you could perform upper extremity surgery irrespective of the site, but also when there is a need to provide anesthesia of combined sites in the upper extremity. There is need for future research and further randomized controlled trials are ongoing in our institution. With these few words, ladies and gentlemen, I'd like to thank you for your attention. Thank you very much.